प्रोग्राम नै एउटा पपुलेसन बेस्ड क्यान्सर रजिस्ट्री नै हो र यसमा पपुलेसन बेस्ड क्यान्सर रजिस्ट्री फर्स्टमा चाहिँ जर्मनीमा स्टार्ट भएको हो ग्लोबल कम्युनिटीमा 1927 र त्यो वर्षदेखि नै अहिले हालसम्म नै यो पपुलेसन बेस्ड क्यान्सर रजिस्ट्री चाहिँ कन्टिन्यू भइरहेको छ र करेन्टली देयर आर द मोर देन 700 PBCR इन द ग्लोबल वर्ल्ड एन्ड कभरिङ द 21% अफ द ग्लोबल पपुलेसन. Neighboring countries China and India has been conducting population based cancer rate since the 1998 and 1963 respectively, and they continue till that. Currently 308 population based cancer registry in China and 26 population based cancer registry in India are running in the neighboring countries. र हाम्रो देशको कन्टेक्स्टमा के छ त पपुलेसन बेस्ड क्यान्सर रजिस्ट्री भनेर भन्दाखेरि चाहिँ हाम्रो देशमा चाहिँ 2018 जनवरी 1 देखि चाहिँ पपुलेसन बेस्ड क्यान्सर रजिस्ट्री सुरु भइरहेको छ र यसको मेजर अब्जेक्टिभ्स भनेको चाहिँ आइडेन्टिफाइङ इन्सिडेन्ट्स प्याटर्न्स ट्रेन्ड्स एन्ड मोर्टालिटी अफ क्यान्सर केसेस इन नेपाल र डेभलप सस्टेनेबल क्यापेसिटी फर द पपुलेसन बेस्ड क्यान्सर रजिस्ट्री इन नेपाल एन्ड सपोर्ट गभर्मेन्ट टु डेभलप द एभिडेन्स बेस्ड क्यान्सर कन्ट्रोल पोलिसी एन्ड प्रिभेन्सन एक्टिभिटिज. डिफाइन्ड जियोग्राफिकल लोकेसनहरू हुनुपर्छ भन्ने कुरा अघि नै डेफिनेसनमा मैले भनिसकेको छु र यसमा चाहिँ नेपालको कन्टेक्स्टमा पपुलेसन बेस्ड क्यान्सर रजिस्ट्रीको लागि डिफाइन गरिएका एरियाहरू भनेको चाहिँ 4वटा प्रदेशमा रहेको छ अहिले चाहिँ. त्यसमा चाहिँ बागमती प्रदेशमा रहेका छन् काठमाडौँ, भक्तपुर र ललितपुर जिल्ला. त्यसपछि प्रदेश नम्बर 2 मध्य प्रदेशमा भएका छन् सिराहा, सप्तरी, धनुषा, महोत्तरी जिल्ला र अर्को लुम्बिनी प्रोभिन्समा इस्ट रुकुम र कर्णाली प्रोभिन्समा वेस्ट रुकुममा चाहिँ अहिले भइरहेको छ. र यसमा चाहिँ पपुलेसन कति कभर भएको छ भन्दाखेरि काठमाडौँ भ्यालीको अब बागमती टोटल पपुलेसनको यो पर्सेन्टेज हो यो 10.60% इन अब काठमाडौँ भ्यालीमा. त्यसपछि मध्य प्रोभिन्समा 9.67% र रुकुम अथवा हिल्ली अथवा माउन्टेन रिजनमा गरेर 0.76% अफ टोटल पपुलेसन. टोटलमा भन्दाखेरि टोटलको इस्टिमेटेड है यो पपुलेसन चाहिँ टोटल इस्टिमेटेड पपुलेसनको चाहिँ 21.03% पपुलेसन चाहिँ पपुलेसन बेस्ड क्यान्सरले कभर गरेको छ. र यसमा चाहिँ हाम्रो गोल भनेको चाहिँ इस्टाब्लिस एन्ड स्ट्रेन्थेन सस्टेनेबल पिबिसिआर इन नेपाल हो. र यो प्रोग्राम लन्च गर्नको लागि चाहिँ हामीले कोलाबोरेटिभ अर्गनाइजेसनहरू चाहिँ मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसन, WHO र IARCको इन्टरनेसनल एजेन्सी फर रिसर्च अन क्यान्सर्स मुम्बई चाहिँ रिजनल अफ मुम्बईसँग कोलाबोरेसन गरेर रनिङ भइरहेको छ. र यसमा चाहिँ कस्तो कस्तो पेसेन्टहरूलाई क्यान्सर पेसेन्ट त तर कुन क्यान्सर पेसेन्टलाई हामीले इन्क्लुजन क्राइटेरियाको रूपमा लिने त भन्दाखेरि पेसेन्ट विथ रिपोर्टेबल मालिग्नेन्सिज अफ एनी साइट डायग्नोस्ड इन द स्पेसिफाइड इयर एन्ड पेसेन्ट सुड बी द रेसिडेन्स अफ द डिफाइन्ड जियोग्राफिकल रिजन लिभ एटलिस्ट 6 months बिफोर द डायग्नोसिस एन्ड रेसिडेन्स अफ डिफाइन्ड जियोग्राफिकल रिजन डाइड ड्यु टु द क्यान्सर इन स्पेसिफाइड इयर. हामीले क्यान्सर इन्सिडेन्स र क्यान्सर मोर्टालिटी दुइटैको तथ्याङ्कहरू निकाल्नुपर्ने हुनाले कुनै पनि स्पेसिफिक इयरमा डायग्नोस भएको र कुनै पनि स्पेसिफिक इयरमा क्यान्सरको कारणले डेथ भएको केसहरू चाहिँ हामीले लिनुपर्ने हुन्छ र त्यो केसहरू चाहिँ डिफाइन्ड जियोग्राफिकल लोकेसनभित्र नै बसोबास गरेको बिरामीहरू चाहिँ हुनुपर्ने हुन्छ. र हाम्रो यो मेथोडोलोजिकल फ्रेमवर्क चाहिँ यस्तो किसिमको रहेको छ जसमा चाहिँ हामीले के गर्छौँ भने हाम्रो एउटा स्टियरिङ कमिटी हुन्छ. स्टियरिङ कमिटीभित्र पनि अब विभिन्न स्टेक होल्डर्सहरू मिनिस्ट्रीदेखि लगायत WHO देखि लगायत विभिन्न एक्सपर्टहरू लगायत अन्कोलोजिस्टहरू लगायतको एउटा कमिटी स्टियरिङ कमिटी बनाइएको हुन्छ. त्यो स्टियरिङ कमिटीको मुनि चाहिँ टेक्निकल वर्किङ ग्रुप हुन्छ जसमा पनि एक्सपर्टहरू अन्कोलोजिस्टहरू विभिन्न सङ्घ संस्थाका माननीयहरूलाई हामीले चाहिँ इन्क्लुड गरेर एउटा टेक्निकल ग्रुप कमिटी गठन गरेको हुन्छ. र त्यसमा चाहिँ हामीले डाटा कलेक्सन गर्दाखेरि अब अघि नै मैले भने मल्टिपल सोर्सेसबाट डाटा कलेक्सन गर्नुपर्ने हुन्छ. यो चाहिँ थ्योरिटिकल फ्रेमवर्क चाहिँ हामीले इन्टरनेसनल कन्ट्रिजहरूमा जुन तरिकाले पपुलेसन बेस्ड क्यान्सर रजिस्ट्री गरिएको हुन्छ त्यही नै वेमा चाहिँ हामीले नेपालमा पनि पपुलेसन बेस्ड क्यान्सर रजिस्ट्री गरिरहेका छौँ. र यसमा चाहिँ हेल्थ फेसिलिटी बेस्ड अप्रोच हुन्छ र कम्युनिटी बेस्ड अप्रोच हुन्छ. हेल्थ फेसिलिटी बेस्ड अप्रोचमा हेल्थ हस्पिटलहरू भयो, ल्याबोरेटरीहरू भयो, हस्पिसहरू भयो, सबै किसिमबाट चाहिँ हामीले त्यो इन्क्लुजन क्राइटेरिया मेट भएका पेसेन्टहरूको चाहिँ विभिन्न तरिकाबाट भेरिफाई गरेर चाहिँ हामीले रजिस्ट्रेसन गर्नुपर्ने हुन्छ. र लगायत कम्युनिटी एप्रोचहरूमा चाहिँ हामीले डेटा मोबिलाइजरहरू डेटा इनुमेरेटरहरू मोबिलाइज गरेर हरेक वडामा, हरेक पालिकामा, हरेक जिल्लामा मोबिलाइज गरेर चाहिँ नयाँ केसहरू पत्ता लगाउने र क्यान्सरको कारणले डेथ भएका केसहरू पत्ता लगाएर हामीले चाहिँ रजिस्टर गर्नुपर्ने हुन्छ. र त्यसरी रजिस्टर गरिएको केसहरूलाई चाहिँ त्यसरी रजिस्टर गरिएको केसहरूलाई विभिन्न तरिकाबाट हामीले भेरिफाई गरिन्छ. रिपोर्टहरू उहाँहरूको रिपोर्टहरू हेरेर अब क्यान्सर एक्चुअली क्यान्सर हो कि होइन, बेनाइन हो कि म्यालिग्नेन्ट ट्युमर हो कि होइन, अथवा डेट अफ डायग्नोसिसहरू अनि रेसिडेन्स कन्फर्मेसन गरिन्छ इच केसलाई फोन गरेर. त्यसपछि सबै किसिमको कन्फर्मेसन भइसके पछाडि हामीले डाटाहरू ग्यादर गरिसके पछाडि डुप्लिकेसन चेक गरिन्छ. डुप्लिकेसन पनि हटाइसके पछाडि फाइनल डाटा.
1 more minute to wrap up.
फाइनल डेटालाई चाहिँ हामीले क्यानरेक 5 सफ्टवेयरमा चाहिँ इन्ट्री गरेर अनि क्यानरेक 5 सफ्टवेयरबाट डाटा एनालाइसिस गरेर रिपोर्ट निकालिन्छ। र हाम्रो प्राइमेरी सोर्सहरू भनेको चाहिँ कम्युनिटीमै धेरै छ, त्यस पछाडि हेल्थ फेसिलिटीहरू नै हो। र यसमा चाहिँ डेटा एनालाइसिस प्रोसेसमा डेटा एनालाइसिस डन थ्रु द क्यानरेक 5 सेक्सन अघि नै मैले भनिसकेँ। फाइनली चाहिँ हामीले चाहिँ एज एडजस्टेड रेटहरू चाहिँ इन्सिडेन्स रेट र एज एडजस्टेड रेटमा चाहिँ हामीले फाइन्डिङ्सहरू निकालिन्छ। र के फाइन्डिङ्स भन्दाखेरि हाम्रो चाहिँ यो नम्बर अफ केसेसमा चाहिँ हाम्रो चाहिँ अब टोटल केसेसहरू हामीले 2019मा 12,338 केसेसहरू हामीले चाहिँ कलेक्सन गरेका थियौँ। त्यसमध्ये चाहिँ 27% चाहिँ हाम्रो इन्सिडेन्स केसको रूपमा रजिस्टर भएको छ भने 12% केस चाहिँ मोर्टालिटी केसको रूपमा रजिस्टर भएको छ। अरू सबै एक्सक्लुडेड भएको छ। एक्सक्लुडेड हुनुमा विभिन्न कारणहरू पर्छन्, जसमा रङ एड्रेसहरू हुन्छ, इन्कम्प्लिट एड्रेसहरू हुन्छ, बेनाइन ट्युमरहरू हुन्छ, होइन, ओल्ड केसेसहरू हुन्छ। त्यो कारणले गर्दाखेरि अरू केसेसहरू चाहिँ एक्सक्लुड भएको पाइएको छ। र यसमा चाहिँ अब हाम्रो कस्तो डाटा देखेको छ भन्दाखेरि क्यान्सर इन्सिडेन्स एन्ड मोर्टालिटीमा हेर्दाखेरि चाहिँ काठमाडौँ भ्यालीमा चाहिँ 86.7% पर लाख पपुलेसन चाहिँ इन्सिडेन्स रेट देखिएको छ मेलमा भने फिमेलमा चाहिँ 90.8%, 90.8 पर लाख पपुलेसन चाहिँ इन्सिडेन्स रेट देखिएको छ। त्यस्तै गरेर सबभन्दा धेरै इन्सिडेन्स काठमाडौँ भ्यालीमा नै देखेको छ। र अरू एसएसडिएम भनेको चाहिँ सिरा सप्तरी धनुषा महोत्तरी हो। सिरा सप्तरी र धनुषा महोत्तरी रुकुममा चाहिँ काठमाडौँ भ्यालीको तुलनामा धेरै नै कम देखिएको छ। र मोर्टालिटी पनि त्यस्तै किसिमले इन्सिडेन्स भएको ठाउँमा मोर्टालिटी हुनु स्वाभाविकै हो। र काठमाडौँ भ्यालीमा मोर्टालिटी चाहिँ 42.1 पर लाख पपुलेसन देखिएको छ भने फिमेलमा चाहिँ 34.43 पपुलेसन चाहिँ मोर्टालिटी देखिएको छ। त्यही किसिमले अरू क्षेत्रमा पनि त्यही किसिमले इन्सिडेन्स मोर्टालिटी चाहिँ देखिएको छ। र एज स्पेसिफिक यस्तै गरेर एज स्पेसिफिक इन्सिडेन्सहरू भनेर हेर्न पर्दाखेरि चाहिँ सबभन्दा हाइएस्ट इन्सिडेन्स रेट चाहिँ 65देखि 70 इयर्सको एज ग्रुपमा देखिएको छ। त्यो चाहिँ तीनवटै जिल्लामा, तीनवटै रेसिडेन्सियल क्षेत्रमा चाहिँ त्यस्तै किसिमको चाहिँ देखिएको छ। र अब लिडिङ क्यान्सर साइडको उसमा भन्नुपर्दाखेरि चाहिँ मेलमा चाहिँ लङ क्यान्सर सबभन्दा हाइएस्ट देखिएको छ। त्यसपछि स्टोमक क्यान्सर, प्रोस्टेट, कोलन, ब्लाडर क्यान्सर, गल ब्लाडर, ल्यारिङ्स, प्याङ्क्रियास कर्मसँग त्यसरी देखिएको छ भने फिमेलमा चाहिँ ब्रेस्ट क्यान्सर हाइएस्ट क्यान्सरको रूपमा देखा परेको छ। त्यसमा दोस्रोमा चाहिँ लङ क्यान्सर, सर्भिस क्यान्सर र गल ब्लाडर, यसै किसिमले ओभरी, स्टोमक, थाइरोइड अनि कोलन क्यान्सर एन्ड कर्पस युटेरी क्यान्सर, लास्टमा रेक्टम, टप 10मा चाहिँ रेक्टमको क्यान्सर देखा परेको छ काठमाडौँ भ्यालीमा भने। र मधेस प्रोभिन्समा पनि त्यस्तै किसिमको सिमिलर किसिमको देखेको छ। र तर मेलमा फर्स्ट लिडिङ क्यान्सर चाहिँ माउथ क्यान्सर देखेको छ मधेस प्रोभिन्समा। र अरू क्यान्सर चाहिँ लङ क्यान्सर, स्टोमक क्यान्सर, त्यो अरू सिमिलर चाहिँ काठमाडौँ भ्यालीको जस्तै चाहिँ देखिएको छ। र अलिकति यो हिल्ली रिजन अथवा रुकुम रजिस्ट्रीमा चाहिँ मेलमा रुकुम रजिस्ट्रीको काठमाडौँ भ्यालीको चाहिँ सिमिलर किसिमको देखेको छ भने फिमेलमा चाहिँ अलिकति सरप्राइजिङली चाहिँ फिमेलमा लङ क्यान्सर चाहिँ हाइएस्ट देखिएको छ। र यसलाई चाहिँ अलिकति पोलिसी मेकरहरूले एडजस्ट गर्नुपर्ने अथवा कुनै क्रिटिकल एनालाइसिस गरेर डिजिज कन्ट्रोलमा चाहिँ अलिकति हेर्नुपर्ने चाहिँ किसिमको लिडिङ साइटहरू देखिएको छ। र अब कम्पेरिजन गर्नुपर्दा 2018 र 2019 को कम्पेरिजन गर्नुपर्दाखेरि चाहिँ 2018मा 95.3 पर लाख पपुलेसन मेलमा थियो भने अहिले चाहिँ 2018मा 95.3 पर लाख पपुलेसन थियो भने 2019मा अलिकति घटेको छ काठमाडौँ भ्यालीमा। त्यो चाहिँ 86.7 पर लाख पपुलेसन देखिएको छ। त्यस्तै गरेर मधेस प्रोभिन्समा सिमिलर किसिमको 2018 र 2019मा सिमिलर किसिमको इन्सिडेन्स रेट देखिएको छ। र रुकुम प्रोभिन्समा चाहिँ अलिकति कम देखिएको छ 2018 भन्दा 2019मा। र फिमेलमा पनि त्यस्तै किसिमको रेटहरू चाहिँ देखिएको छ।
तपाईँ कन्क्लुड गर्नुहोस् न।
हस्, थ्याङ्क यू।
थ्याङ्क यू।
सबै प्रेजेन्टरलाई एउटा रिक्वेस्ट के छ भने तपाईले यो अडियन्सलाई के मेसेज दिन चाहनुहुन्छ आफ्नो टपिकबाट, यु सुड कन्सन्ट्रेट अन द्याट, हैन। हामीले अब बहिनीले हामीलाई धेरै कुरा सिकाउनु भयो क्यान्सरको बारेमा, तर यो अडियन्सले यसको के हो त, यसको इम्प्लिकेसन देशलाई के हुन्छ र यसको के मेसेज लिएर हाम्रो अडियन्स जान्छ, त्यसमा बढी कन्सन्ट्रेसन गर्नु होला। एन्ड नाउ आई रिक्वेस्ट मिस्टर राजेन्द्र गौतम फर हिज प्रेजेन्टेसन अन स्क्रब टाइफस एन्ड मर्कुलर क्राइसिस।
स्लाइड्स होइन यो खोल्दै हजुर ए उतैबाट हो गुड आफ्टरनुन के थियो भाइ यसको Good afternoon, respectable chair, and all the ladies and gentlemen out here. Myself, Mr. Rajendra Gautam, PhD scholar, Institute of Medicine, TUTS, Kathmandu, Nepal. And today I am going to present on my PhD thesis, a part of my PhD thesis, and that is the molecular characterization of Orientia susugamusi, the causative agent of scrub typhus, which is the major cause of scrub typhus in a present situation. So here I go. Scrub typhus is a mite-borne acute febrile illness which is caused by the bacteria known as the Orientia susugamusi. This bacteria is most commonly found in the Orientia, most in the Susugamusi triangle, but the recent report of this bacteria beyond the Susugamusi triangle has raised concern about its presence worldwide. National scenario: 3 months after the devastating earthquake in Nepal in August 2015, BP Koirala Institute of Health Sciences had alerted EDCD that the children with fever and severe respiratory feature had not been responding to the usual course of the antibiotics. This clinical anomaly was first thought to be hantavirus infection, but when it was tested in the lab, it came out to be negative, so this was not the hantavirus. And later on, these serum samples were transferred to the NPHL Kathmandu, and they were tested for panel of viral diseases. And all the viral diseases also came out to be negative, and at last they were tested for the scrub typhus, and which came out to be positive. And by this, it came to be known to the scientific community and the clinician that the scrub typhus was the cause which was causing acute febrile illness in BPKIHS or in the eastern part of Nepal. And to further confirm these cases which were diagnosed by the ELISA, these samples were sent to the Armed Force Research Institute of Medical Sciences in Bangkok, Thailand, and there these samples were tested by the gold standard immunofluorescence assay, and when they were tested by immunofluorescence assay, this sample turned out to be positive of the Orientia susugamusi. And a total of 101 cases were identified in 2015, and out of them, 8 cases died, leading to the crude fatality rate of 8%. Our objective, the main objective of this study is the scrub typhus and molecular characterization of Orientia susugamusi from central Nepal. And specific objective evaluation of PCR for the diagnosis of scrub typhus in Nepal. This was done first time in Nepal, this evaluation. And then also we found the possible phylogenetic linkage between the different types and source of infection. For this, we took the ethical clearance from the ethical review board, institutional review board of Institute of Medicine. And this was the descriptive cross-sectional study. And study site was Chittagong Medical College, Chittagong, and Tribhuvan University Teaching Hospital, Kathmandu. And this molecular analysis was carried out at the Australian Rickettsial Reference Laboratory, Geelong, Victoria, Australia. This is the WHO collaborative laboratory for the diagnosis of the rickettsial infection. On study population taken were the acute febrile illness patients with suspected scrub typhus, and the sample size was 358 EDTA blood samples were included for the molecular study. This molecular study is also part of the study of the scrub typhus, in which total samples were 1585. And molecular studies was done by the DNA extraction, and DNA was extracted from the Buffy-Coat sample using the DNA extraction kit. Then at first we have done the real-time PCR or qPCR for Orencia susugamusi by using the following primers and probes. And later on, we have done the conventional PCR. In the conventional PCR, we had targeted the 56 kilodalton type specific antigen by using the primers and probes given as follows. A real-time PCR result and 29.59% of the cases were found to be positive by real-time PCR or qPCR. And after confirming by the real-time PCR, those those samples with high level of CT value, they were subjected for the amplification of 56 kilodal KDA gene by conventional PCR in the agar gel electrophoresis. Here we have named our sample is Nepal 1, Nepal 2, Nepal 3, and so on. We have subjected 10 samples for the conventional PCR. And based on the DNA sequences which were obtained by the conventional PCR, we have sent for the DNA sequencing by those nucleotide sequences. And based on these nucleotide sequences, we have constructed the phylogenetic tree. Discussion in the present study, qPCR based on the 16 years rDNA showed 29.59% positivity, and these diagnostic sensitivities of different PCR method have been shown to be 0 to 100% according to the various scientific reports. A plausible reason for the poor sensitivity could be the initiation of a specific therapy in most cases before sending the samples for diagnosis. In the present study, serotype strain based on the 56 kilodalton gene showed that study isolates were of CAP serotype strain. This serotype strain isolated from Nepal are closely related with the strains which were isolated from the Guangdong, China and Thailand. Guangdong has a tropical and subtropical monsoon climate with long time summer and abundant monsoon, which is similar with the climate of Nepal. So these environmental factors might have played a major role in the presence of the same type of strains in our country and in China and Thailand. And when we did the DNA sequencing, we found the CAP-like serotype as the most common serotype present in approximately 40% of the isolates. And these CAP-like serotype strains are more prevalent worldwide, reported by the serological testing and genotyping in Southeast Asia,
1 minute.
Vietnam, Thailand, Philippines, Malaysia, and Cambodia. Conclusion, real-time PCR, qPCR based on the 16 years rDNA showed 29.59% positivity. The achievement of our study is identification of the novel strain, which is CAP-like serotype strain, which is circulating in our country. Recommendation, this is the first molecular evidence for the scrub typhus in our country. And more prospective studies need to be done on this neglected illness and bring awareness among the local communities and physicians about this re-emerging endemic disease. Acknowledgement, I would like to acknowledge my supervisor, Professor Dr. Keshav Parajuli and Professor Dr. Jivan Bahadur Serson, my external examiner during my PhD thesis defense, Professor Dr. Prakash Gimire, and external examiner, Professor Dr. Bharat Mani Pokhrel, co-author, Professor Dr. Stephen Graves, and Professor John Stenos, and all the faculty members of Institute of Medicine and Australian Rickettsial Reference Laboratory. Thank you.
Thank you. Thank you, Rajendra. Without wasting time, let's move to the third presenter on the seroprevalence of dengue fever in central region of Nepal, to be presented by Ms. Mandira Adhikari. Please go ahead. तपाईहरुले 9 मिनेटमा अलर्ट पाउनुहुन्छ, 1 मिनेटमा र्याप अप गर्नुपर्छ है।
Honorable chairs and respected all the members over here, present over here. Thank you NHRC for letting me this golden opportunity to speak today at the 8th National Summit of Health and Population Scientists in Nepal. Today I'm going to present my research on the topic of seroprevalence of dengue fever in central region of Nepal. This is the list of my co-authors in alphabetical order. Outlines, there are background, objectives, methodology, results, limitations, conclusions, and about me. First, I would like to go through background. Dengue virus infections annually affect 390 million individuals worldwide, where 96 million are manifested clinically and 3.9 billion are more at risk. This is an underestimate because of the limited surveillance. According to WHO, dengue fever is classified into 3 categories. They are dengue with warning signs, dengue without warning signs, and severe dengue. Symptoms lasting 2 to 7 days include high fever, 40 degrees Celsius, and accompanied by any 2 of the following symptoms: severe headache, pain behind the eyes, muscle and joint pains, nausea, vomiting, swollen glands, and rash. Dengue is transmitted by female mosquitoes, Aedes aegypti, which is found in tropical and subtropical areas, and Aedes albopictus mosquitoes found in temperate regions. Both of these species are reported in Nepal. Dengue in Nepal is first reported in 2004, following the first outbreak in 2006. There have been multiple outbreaks since then. With yearly outbreaks in recent years, limited information is available on the prevailing serotypes. The objective of my study is to investigate the serology coupled with demographic features and to describe the regional epidemiology of dengue. The methods. A descriptive cross-sectional study was conducted in 3 different health settings in Nepal, namely Primary Health Center Sarlai, Bardivas Hospital Mohottari, and Dhading District Hospital Dhading. From June to November 2019, total 216 blood samples were collected from patients of all ages and sexes having suspected dengue infection. This is the sampling size. Now laboratory procedures: 3 to 5 ml blood samples were collected and then serum was separated. Serology was done at Mycobacterial Research Laboratory, Anandabhan Hospital, Lalitpur. And the method was IgM capture ELISA using IgM ELISA kit. The focused diagnostic dengue virus IgM capture DX selectium. Now result: dengue in sexes, out of 106 male, 24, that is 61.5% were found positive, which is higher than female. Dengue in ages, out of 130 patients from age group 15 to 50 years, 27, that is 69.2% were found highest, which is followed by age group less than 15 years. Dengue in geography, among hilly region and Tarai region, dengue seropositive cases were found highest in Tarai region, that is 87.2%. Dengue in occupations, among different occupations over there, students, that is out of 65 students, 11, that is 28.2% were found dengue seropositive highest cases, which is followed by housewife, that is 8, 20.5%. Dengue in seasons, among monsoon and post-monsoon seasons, 135 samples were from post-monsoon season, which is highest in seropositive dengue cases, that is 27, 69.2%. This is epidemiological curve. Among 6 months, there were highest positive, seropositive dengue cases in the month of October, that is the number of cases were 11. Now, clinical features in seropositive dengue cases. The most common clinical features was fever, which is followed by severe headache, and then muscle pain. The limitation of my study, since D-League serum samples were collected, all of the samples were not the representative of the total populations. All epidemiological parameters are not taken. Since selection of cases was based on the clinical diagnosis, other infections rather than dengue virus may confuse the dengue. Since the test is based on IgM capture ELISA, early stage infection can be seems negative, whereas past infection or any other flavivirus infections may seems false positive. The conclusion of my study is there is the high seroprevalence of dengue. Since so, the larger serological surveillance should be conducted frequently, and effective mosquito vector control measures should be employed. About me, namaste everyone. I am Mandira Adhikari, fresh postgraduate in MSc Medical Microbiology from Sigon International College of Science and Technology. Thank you for your time. Thank you, everyone.
Thank you, Mandira, keeping your time. I now pass on to my co-chair to announce next.
I request Pramod Kumar Mehta for his presentation.
Respected chair and co-chair and all delegates, very good afternoon. So today's my presentation is assessment of antigenemia of lymphatic filariasis among children born after mass drug administration in Salyantar, Dhadi. This is my research title. So this is my outline of presentation. Introduction. So lymphatic filariasis is a disease which is caused by the lymphatic group of nematode. More than 90% lymphatic filariasis is caused by the Wucheria bankruptcy. Similarly, Wucheria bankruptcy, Brugia mala and Brugia tumor. These three are the main nematode which transmit the disease. So these parasites are transmitted by the different vector such as Anopheles, Culex, and Mansonia. More than 90% transmission is transmitted by Culex, Kunki, faciatus, mosquito. So main vector is Culex, Kunki, faciatus. So globally, 1.3 billion people are at risk of infection, and more than 80 countries are endemic with lymphatic filariasis. But in case in our country, more than 61 districts are endemic with lymphatic filariasis. So our government annual mass drug administration to eliminate lymphatic filariasis was launched in 2003 for break the chain of transmission. So in 51 districts, 6 rounds of MDA were completed in 2017. Antigen survey was carried out in 2017 as a part of transmission assessment survey to assess the impact of the program. Is it transmission is breakout or not? So result indicated that in most of the districts there is no transmission, recent transmission, but due to a cluster of antigen positive cases in some foci, so this study purposed to assess the prevalence of these foci. There may be a risk of transmission, or there is a local transmission, so this study purposed. So this is my major objective of my research, to assess the antigen prevalence of LF in selected endemic district of Nepal, to assess the clinical manifestation of LF in selected endemic district of Nepal, and to assess the MDA complaints concerning lymphatic filariasis infection status. So this is my research objective, and this is my study area, materials and methods. So area with persistent infection can be considered as a hot spot. And this risk of infection in such hot spot is to be investigated to suggest transmission status of lymphatic filariasis. So study, Dading is my study area, one of the study area. So this table is showing the, in my study area, reported transmission coverage during DEC and albendazole MDA intervention in Soliantad Dading. From 2007 to 2013, 6 rounds of MDA were completed. And 2008, there is no MDA was implemented by our government. So this is coverage and targeted population. So sample size 194 samples were calculated for this study. So materials used in my study, these are the different materials which was used, mainly immunochromatographic test kit, ICT kit was used, and GPS and Lancet. These are the different materials which was used in my study. So data collection of blood by finger prick method, immunochromatographic test for antigen prevalence, and data analysis. Data were entered in Excel spreadsheets and subsequently analyzed with Minitab 17 version. This software which I was used my analysis of data. So MF prevalence, chronic clinical manifestation, and geographic characteristics and MDA complaints were analyzed by the chi-square test. And upper and lower limits of the 95 confidence interval are calculated. Result, antigen prevalence and disease burden, MDA complaints concerning lymphatic filariasis infection status, prevalence trends of LF antigen based on TAS report and current study report. So antigen prevalence and disease burden, so a total of 202 individuals, 5 to 12 years old children, samples in Soliantad Dading district were examined for antigen. Hydrocele and elephantiasis, the overall male-female ratio was 1:1, and the mean age of the participant was 9.1 years. So range of the participant was 6 to 12 years. So of 202, 9.9% out of 202, that is 20 persons have CFA, circulating filarial antigens. Positive cases was found in my study. Among the infected people, the antigen infection was not cooperatively varied between male and female. So there is no significant variation was found in case of male and female. And of 2 individuals found with the chronic clinical manifestation such as hydrocele, and there is no any cases was found, elephantiasis cases was found in this age group. And no any individuals with hydrocele or elephantiasis with have circulating filarial antigens was found in my study. So table 2, this table is showing there is a coverage in male, female, and a different age group and different ethnic group, and there is a range of probability of range of prevalence of CFA in my study. So this table is showing this probability of prevalence and coverage rate of in my study. So in this table, there is showing that there is no significance difference was found in case of in male and female. There is no any significance and different age group. And this table, there among the infected people, the antigen infection was not cooperatively varied among different ethnic group. And this last table, this showing the trends of prevalence of LF antigen and antigen in my study. So current report showing that increasing and prevalence of circulating filarial antigen in my study in compared to baseline data, pre-TAS, TAS1 and TAS2 report. So this is a summary of my infection transmission parameters in my study area. So conclusion, analysis of indices of LF infection in the human population demonstrated a increasing in the prevalence of new infection of lymphatic filariasis in the study areas with compared with baseline values before a start of the elimination activities, similarly pre-TAS, TAS1, TAS2 report after MDA program. Hence, to understand the transmission dynamics of the disease in present context, further filarial survey along with genome editing is recommended. So we recommend formal TAS to be conducted in a study to make an informed decision to either MDA will be continued or stopped. So formal task to be conducted. Acknowledge, I am highly acknowledged to my esteemed guide and my HOD, head of department, and female health volunteers, University Grant Commission to support my this research. Thank you.
Thank you, Pramodji, for keeping the time. We now request the fifth presenter, Dr. Vivechan Thapa, on patterns of use of antibiotics in hospitalized COVID-19 patients in a tertiary care center in Lalitpur district. Dr. Thapa, your time starts now.
Good evening, everyone. Namaste. I am Dr. Vivechan Thapa. I graduated 2 years ago from KIST Medical College and currently working as house officer at Nepal National Hospital, Kalanki. Respected chairs and dignitaries, today my topic is patterns of use of antibiotics in hospitalized patients with COVID-19 in a tertiary care center in Lalitpur district of Nepal. And we 5 are the co-authors of this study. Going to the background of this study, as we know, antimicrobial resistance is a global health problem and is a major threat to global public health. AMR is emerging as a serious concern all over the world due to increasing incidence of resistant human pathogens like multi-drug resistance, extremely drug-resistant pathogens, which are very difficult to treat. It also hinders the treatment of bacterial infection, which lead to significant increase in morbidity and mortality among the vulnerable age group. It is also the improper and widespread use of antibiotics is the leading cause of AMR in our context. So where does COVID-19 come in this picture? COVID-19, as we all have witnessed, has disrupted health delivery system all around the world. And undoubtedly, it has impacted the antimicrobial stewardship programs and single-handedly also increased the global use of antibiotic, causing a cascading effect on already existing problem of AMR. Theoretically, we know that COVID-19 is a viral disease and thus is not treatable by antibiotics. But we should also know that the viral respiratory infection can clinically progress to bacterial infection requiring antibiotic administration for the treatment. Infectious Disease Society of America has estimated that the bacterial co-infection rate was 8%, and different national and international study also shows that the rate is 1 to 15%. This co-pathogenesis is the basis for use of antibiotics in the management of COVID-19 patients, saying that we should be very alert during this crisis in order to address this problem, in order to prevent the emergence of AMR. So with this, we conducted our study, and with this rationale, we conducted our study in order to generate a baseline information about the patterns of use of antibiotics in COVID-19 management. Regarding the methodology, we took ethical approval from the Institutional Review Board, KIST Medical College, and conducted this cross-sectional study. The study was conducted retrospectively during the period of 3 months, using the data from April to June 2021. And hospitalized COVID-19 patient admitted in COVID-19 dedicated wards, SDU and ICU were our study population. As this is a census study, all the cases in that time frame were included in the study, and the total number of cases were 106. All the cases of COVID-19 proven by RT-PCR for SARS-CoV-2 were included in the study. We retrospectively reviewed patient's medical record from medical department, and the cost of antibiotics were collected from the hospital pharmacy. We documented required data on structured pro forma, which we developed based on our objectives, and pre-tested it before collecting the data. Major limitation of our study was that it is a single center study with a comparatively small sample size, so the result may not be generalizable to other setting and in general population. For data entry and analysis, we use SPSS software. Descriptive statistical tools were used to generate data in a form of frequency, percentage, mean, and standard deviation. Chi-square test was also done to find the association between different categorical variables like age, gender, severity of disease, need of ICU level care, and ventilatory support status with number of antibiotic use and cost of the antibiotic. Going to the result section, the mean age of our patient was 55 years with range from 15 years to 91 years, and male to female ratio was 1.12. Regarding the severity of the disease, 30.2 were mild, 34.9 were moderate, and rest 34.9 were severe COVID-19 disease. So with this table, what I want to show is almost all mild cases and almost all moderate cases were managed in ward setup, and severe cases were treated in ICU setup. The mean number of antibiotic used per patient was 1.8, and here we can see that more than 98% patients were treated with at least one antibiotic, and about 70% patients were treated with 2 or more antibiotics. Also, we can see here is more than 93% patients were treated with intravenous route of antibiotics. And the mean duration of use of antibiotics was 6.4, ranging from 1 day to 24 days. And 77% patients were treated for 7 days or less. The mean estimated cost on antibiotic therapy was 4,645 rupees with range of 150 rupees to 54,000 plus. And 40.6% patient paid 1,200 rupees or less for their antibiotic treatment. 17 different antibiotics were used belonging to 7 different antibiotic classes. Cephalosporin and macrolides were the most commonly used antibiotic classes. Belonging to these groups, ceftriaxone and azithromycin were most commonly used. We can see that use of 3rd generation and 4th generation cephalosporin and carbapenem group of drugs. Meropenem, we found that meropenem was exclusively used in patients with ventilatory support, and antibiotics like piperacillin and 3rd generation and 4th generation cephalosporin with beta-lactamase inhibitors were used in critical care setting. With this, what I want to show is there is significant association between level of care and ventilatory support status with number of antibiotics used. And in this table, we want to illustrate that there is significant association between severity of disease, level of ICU care, ventilatory support status with estimated cost of the antibiotic therapy. With this, what we can conclude is the potential bacterial co-infection is the basis for use of antibiotics in COVID-19 management. The rate and the number of antibiotics used in the patient with COVID-19 is high, even for mild to moderate case. The most common classes of antibiotics were cephalosporin and macrolides, particularly ceftriaxone and azithromycin. Higher classes of antibiotics like fourth generation cephalosporin and carbapenem group of drugs like meropenem were mostly used for the management of the severe cases in ICU setup and with ventilatory support. And there was significant association between ICU level of care and ventilatory support with number of antibiotic use, and so is true for cost of antibiotic used. With this, what we can recommend is we have to promote, practice and advocate for the appropriate and scientific use of antibiotics in COVID-19 patient. This is the high time to act so that we prevent the dreaded complications like AMR during this crisis era. For this, we have to formulate a robust antibiotic stewardship program and surveillance system. For this, stakeholders like government, different level of government bodies, local health institutions like NHRC, and health activists like you and me should act upon so as to prevent the condition of emergence of antimicrobial resistance. With this, I would like to conclude. Thank you very much for being a wonderful audience. And yes, this is me.
Thank you. Thank you for keeping your time, Dr. Thapa. Please have a seat. We both the chairs have discussed keeping in view of the time and the late start of the program. We'd like to take 10 minutes for the question and answer for those who have already presented, so that we can move to others after that. You will not forget the questions which are born in your mind after hearing the presentation. The floor is open. Raise your hand and you may ask questions if you have, or any comments for the first 5 presenters. सबैजना थाकिसक्नुभयो कि क्या? The presenter himself have some question. Let's hear from him, because he didn't hear from you people. Probably it induced him to make a question. Please.
मेरो क्वेसन चाहिँ राजेन्द्र सरलाई अब कहाँ हुनुहुन्छ ए राजेन्द्र सर स्क्रब टाइफसको सर why scrub typhus cases were increases after earthquake of 2072 यो 2072 पछिको अहिले रेकर्डमा के देखाएको छ भने यो केसहरू चाहिँ एकदम बढेको त्यसको फिलोसफी चाहिँ के हो खास यो हजुरको
थ्याङ्क यू फर य क्वेसन र के छ भन्दाखेरि जस्तो हामी चाहिँ अर्थक्वेकले गरेर जुन ठाउँमा चाहिँ घरहरू भत्कियो जुन ठाउँमा चाहिँ मान्छेहरूले सेल्टर नपाएर चाहिँ बाहिर बस्नु पर्यो त्यो बेलामा चाहिँ यसको केसहरू चाहिँ धेरै देखियो भने जस्तो लागे पनि यो केसहरू चाहिँ पहिल्यैदेखि नेपालमा थियो तर यसको डायग्नोसिस चाहिँ थिएन त्योभन्दा अगाडि 2015 भन्दा अगाडि स्क्रब टाइफसको डायग्नोसिस कसैले पनि गर्दैनथ्यो एक्युट फेब्राइल इलनेस भयो भने टाइफाइड होला भनेर एन्टिबायोटिक दिने चलन थियो एउटा त हैन त्यो भएर त्योभन्दा अगाडि साइन्टिफिक कम्युनिटी फिजिसियनहरूले चाहिँ टेस्ट गर्न नपठाएको पनि हुनसक्छ एउटा कुरा हैन त्यो टेस्ट चाहिँ नेपालमा एभाइलेबल नभएको भएर नदेखिएको पनि हुनसक्छ अर्को चाहिँ अब जब देखियो मासमा देखिसकेपछि अनि बल्ल चाहिँ हाम्रो चाहिँ ध्यान त्योतिर गयो ए छ है भन्ने कुरा चाहिँ हामीलाई थाहा भयो अनि त्यो पछाडि बल्ल अहिले चाहिँ रुटिन अब जस्तो एक्युट फेब्राइल इलनेस फिभर छ भने रुटिनली चाहिँ स्क्रब टाइफस छ कि भनेर हामी चाहिँ चेक गर्छौँ अहिले अब पहिला एउटा त चेक पनि भएन अर्को कुरा त्यस्तो मास केसहरू पनि देखिएन तर छन चाहिँ यो 1981 देखिबाट नै नेपालमा छ भनेर डिफ्रेन्ट पहिलाको चाहिँ प्रिभियस जब हामीले चाहिँ यसको हिस्ट्री हेर्छौँ त्यो बेलामा चाहिँ पहिल्यैदेखि छ भन्ने कुरा चाहिँ थाहा हुन्छ
Thank you, Rajendra, for your response. Any other questions? from the audience? Okay, कसैको कोही क्वेसन छैन भने लेट्स ट्राई टु सी म क्वेसन सोध्छु उमाजीलाई पहिलो क्वेसन फर द इन्भाइटेड टक हैन we see that this cancer registry is very useful to understand which kind of cancer are present in the community and what kind of interventions are required in specific communities. So what is the expansion planning in the coming years and what is your expected delivery with those interventions?
क्यान्सर रजिस्ट्री अहिले 9वटा जिल्लामा 2018देखि नै सुरु भइरहेको हो र यसलाई एक्सपान्सन गर्ने प्लान त छँदैछ। अब यसमा कसरी प्रोभिन्सियल कोअर्डिनेसन गरेर अगाडि बढ्ने, हरेक प्रोभिन्सलाई समेटेर हरेक प्रोभिन्सका सबै जिल्ला समेट्न नसके पनि केही केही जिल्लाहरू समेटेर जाने अगाडि प्लान छ र यसलाई हाम्रो अब यो रिपोर्ट हामीले मिनिस्ट्री अफ हेल्थ एन्ड पपुलेसनमा पनि हामीले डिस्ट्रिब्युट गरेका छौँ र यसअनुसार अब हाम्रो लिडिङ साइटहरू देखेको छ, त्यो किसिमको पोलिसीहरू डेभलपमेन्ट गर्नुपर्ने अवस्था चाहिँ छ हैन। हामीले एउटा दिने भनेको एउटा साइन्टिफिक इभिडेन्स हो, त्यो भनेको क्यान्सरको बर्डन कम्युनिटी बेस्डमा एक्चुअल बर्डन कहाँनिर कस्तो छ त भन्ने कुरा एभिडेन्स चाहिँ छर्लङ्ग देखिएको छ क्यान्सर रजिस्ट्रीको उसमा र यसलाई चाहिँ अझै एक्सपान्सन गर्ने प्लान त छ, तर अहिले रिसेन्टली नै कसरी गर्ने भन्ने कुरा चाहिँ त्यो सबै चाहिँ भइसकेको छैन।
Thank you. Another question goes to Mr. Mehta. Normally, our understanding is mass drug administration is the bullet which kills all the disease and there won't be any transmission more. When we see Sallantar as an example, यो चाहिँ सदियौँदेखि चल्दैछ र सल्यानटारमा अब कति वर्ष यो लिम्फेटिक फेलियोसिस चल्छ जस्तो लाग्छ तपाईलाई?
यो सल्यानटारमा चाहिँ अब झन् भयानक अलि बढ्छ कि केस भनेछ सर। त्यहाँ त पुरै प्रत्येक घरमा गयो भने इभन माइक्रोफिलेरिया र यो प्रत्येक घरमा लगभग पुरै फ्यामिली नै इन्फेक्टेड छन् त्यहाँ त।
अनि यसको क्वेसन चाहिँ के हो भने सल्यानटारमा एमडिए इज नट इफेक्टिभ ओर औषधि खोलामा रजिस्टर झोलामा हो?
हो, त्यहाँ चाहिँ मेन प्रब्लम के हो भने सर एउटा चाहिँ माइग्रेसन हो। अब मैले गभर्मेन्टलाई दोष दिनुभन्दा पनि मैले एज अ रिसर्चर होइन, मैले गभर्मेन्टलाई मैले दोष दिन खोजेँ।
खाए पनि ठिक नहुने हो कि किन हो भन्नु सोध्नु खोजेँ मैले। तपाईँ त त्यहाँ काम गर्दै हुनुहुन्छ, यु मे नो द इनसाइड स्टोरी।
त्यहाँ
बढ्यो तर कारण होला नि त।
हजुर, मेन मेडिसिन चाहिँ मान्छेहरूले ल्याएको छैन, प्रोपरली ल्याएको छैन।
हो, मेन तपाईँको मुखबाट आई वान्टेड टु हियर सेम, मेन मेडिसिन ल्याएको छैन।
मेन मेडिसिन लिए पनि विश्वको स्टडी तपाईँले हेऱ्यो भने फेलिरियसिसमा इभन आई से यो रेफरेन्स फ्रम द बङ्गलादेश, एभ्री स्टडी हेज सो देयर इज अ लो antigenicity if you drug administration. How it could be possible that mass drug administration will not increases the antigenicity?
यस सर, यो एन्टिजनको मेन चाहिँ डिटेक्सन गर्ने यो मैले चाहिँ एज ग्रुप जुन दिएको छु 6 to 12 इयर्स भनेको त्यो एमडिए पछि जन्मेको बच्चा जसले कि त्यो मेडिसिन लिएकै छैन त्यो बच्चाहरूमा गरेको छु म। त्यो गर्नुको मिनिङ के हुन्छ भने त्यहाँ चाहिँ न्यू इन्फेक्सन छ कि छैन भने मैले बुझ्ने हो भन्नाले। अब लोकल ट्रान्समिसन हो भनेर मैले चाहिँ भन्न सक्दिनँ किनभने एभिडेन्स मसँग त्यति छैन, तर देयर इज न्यू इन्फेक्सन। मैले चाहिँ न्यू इन्फेक्सन हो चाहिँ भन्न मिल्छ किनभने मैले एन्टिजन डिटेक्सन यो चिल्ड्रेन बर्न आफ्टर एमडिए भनेको मेडिसिन लिँदै नलिएको मान्छेमा केस चाहिँ देखियो को मिनिङ त्यहाँ चाहिँ नयाँ केस छ। त्यति चाहिँ मैले यो एभिडेन्सको बेसमा चाहिँ त्यति चाहिँ भन्न सकिन्छ। र त्यहाँ चाहिँ के प्रब्लम के हो भने सर, अब त्यहाँ पोजिटिभ केस धेरै छन्। त्यहाँ सोद्धाखेरि मान्छेहरूले कोही अब गभर्मेन्टको कभरेज रेटमा हेर्ने पनि मोर देन 65% हेभ टेकेन द डिएसी एन्ड अल्बेन्डाजोल, तर गभर्मेन्टको रिपोर्टमा देखिन्छ तर प्रब्लम के हुन्छ मान्छे लिन्छ स्वयंसेविकाबाट अनि घरमा गएर लुकाएर राख्छ किनभने त्यहाँ पोजिटिभिटी बढी छ कम्प्लिकेसन आउने सम्भावना त्यहाँ बढी छ मान्छेहरू फेन्ट हुन्छ बेहोस हुन्छ र त्यो कारणले पनि डराएर मान्छे ल्याएको छैन कभरेज गभर्मेन्टको कभरेजमा चाहिँ देखाएको छ सर त्यो कभरेज चाहिँ देखिन्छ तर रियलमा चाहिँ होइन सर मैले त्यहाँ चाहिँ अर्को त्यहाँ चाहिँ जियोग्राफी पनि त्यस्तै खालको छ वाटरहरू स्ट्याग्नेन्ट हुने भेक्टरको सुइटेबल इन्भाइरोमेन्टहरू पनि छ र अर्को माइग्रेसन त्यहाँबाट विदेश जाने मान्छेहरू धेरै छन् बाहिर आउने अनि धेरैजनाले मेडिसिन नलिने त्यस्तो खालको त्यहाँ प्रब्लमहरू छ अर्को इम्युनोलोजिकल अर्को रेसिस्टेन्टको केसहरू हुनसक्छ जस्तो कपिल वस्तु अहिले गभर्मेन्टले यो आइभरमेक्टिन चाहिँ दिइरहेछ के अरे अब त्यो प्रब्लमहरू त्यो फर्दर रिसर्चको कुरा हो सर त्यो चाहिँ मैले गरेँ होइन
Thank you, Dr. Mehta.
Ask one question from Dr. Vichan Thapa. What is your idea about the misuse of antibiotic in your study? Because 1/3 of the misuse of antibiotics in the Asian country. Did you find any misuse in your study?
Hello. Thank you for the question, sir. Definitely some sort of misuse the sir. तर त्यसलाई हामीले के भनौँ मेजर चाहिँ गरेनौँ किनकि त्यसको लागि चाहिँ मैले प्रो इन्फ्लामेटरी मार्कर्सहरूसँग मैले मेरो एन्टिबायोटिक युजको रिजल्ट ट्याली गर्नु पर्थ्यो अनि कल्चर्सको रिपोर्टहरूसँग ट्याली गर्नु पर्थ्यो त्यो चाहिँ मैले गरेको थिएन त्यो मेरो अब्जेक्टिभभित्र नपरेको हुनाले चाहिँ मैले ठ्याक्कै यो कति छ भनेर चाहिँ भन्न सकिनँ सर तर त्यो पनि एउटा फर्दर रिसर्चको विषय हुनसक्छ सर थ्याङ्क यू सर
अडियन्सको केही अरू छ रे
Good afternoon, good evening. I am Dr. Anish Mudwari from Department of Pharmacology, Institute of Medicine. I would like to ask Dr. Thapa, who presented, I would like to congratulate him for presenting this research entitled Antimicrobial Use, Antibiotic Use in COVID-19 era, second wave, during a second wave. So I wanted to know if there has been any therapeutic antimicrobial change. Supposedly, most of the antimicrobials that have been used on an empirical basis, based upon science symptoms. Have there been any cases where definitive therapy was started, like drug was initiated after drug sensitivity, culture sensitivity report? Or was most of the antimicrobial use, were they done on an empirical basis, or was there a definitive indication after culture and susceptibility test? And that was one question. And the other is, were there any, among, I think it was 119 cases, 119, 119, 116 cases, okay. So among them, how many of therapeutic interchange or antimicrobials were there? So because that would reflect the suboptimal efficacy of antibiotics, probably contributed by a resistant strain of bacteria. So did you understand my questions?
I think I get your first part of the question.
Okay.
Most of the cases, most of the antibiotic was used in first day of admission. So it is vivid that it was empirically used, and what I want to say is, as I already mentioned, I do not check the pro-inflammatory markers like procalcitonin, or I do not cross-check with culture report. So I am not able to comment on your first part of the question. But yes, antibiotic was empirically used. I can say that because they were used at the first day of admission. Okay. And second part, sorry, I did not get your
Were there any therapeutic interchange due to suboptimal efficacy, probably the cause being the contributor being the resistant strains? So we had to change from like supposedly from ceftriaxone to it could be combination of sulbactam and piperacillin, or it could be meropenem. How many cases of therapeutic or we could say therapeutic interchange or substitutions?
We did not approach like that. The ceftriaxone was changed into oral form oral form was changed to the oral form, but I do not think we look into the therapeutic substitution. So I cannot comment on that, sir. Thank you.
Okay,
Thank you
thank
for
you.
your answer.
Thank you, thank you. At least one good question from the participants, so that it shows that participants are interested in your presentation, whatever you have done. So without wasting time, let's move to number 6 presentation, the impact of basic police training and scale diet on body composition and aerobic performance of Nepal police officers, trainees, presented by Dr. Vivek Rajvanari. Dr. Rajvanari, please.
Slide, please. So, namaste everyone. Today my research title is The Impact of Police Training, Basic Police Training on the Body Composition and the Aerobic Fitness. These are my author list and their affiliation. The author are diverse, ranging from the physical trainer to the epidemiologist. So in the background, we all know that for the police officer to fulfill their duty, they need to be very fit. And on that background, to maintain the criteria of fitness, the graduating police officer must be in appropriate aerobic condition and also in a good shape. So with this in mind, our objective of the study was to find out the impact of basic police training in a graduating police officer and in body composition and aerobic fitness. So the study framework was like this. The recruited trainees from the Lok Sewa were first recruited by the same procedure, and as soon as they enter the basic police training centers, they were given a orientation class where it was regarding the training and the research and the system of performance, where they were given a consent sheet. After signing the consent sheet, they were given a first measurement was done. The measurement was of the body composition and aerobic fitness. The parameter was VO2 max and the fat percentage. As soon as they enter the traditional police training, which is a mandatory training, not an exposure, but a mandatory training, not an assigned exposure, but a mandatory training, they were given a fixed protocol of exercise. There were 5 different programs in whole exercise, ranging from the metabolic equivalence of 6 to 12, and each program lasting for 1 hour. And regarding this fixed scale diet, the calorie was 3,800 calorie and 115 grams per day. In that fixed diet, being in that fixed diet, we again measured the second measurement was done in the 3rd month of the confinement period. So with this in mind, my study design was a cross-sectional analytic study, which was done for 3-month period of time from March to June 2019 in the Nepal police recruits, which was in 2019. The study site was Nepal Police Training Center. There were 23 different centers all over the Nepal. and the study was conducted after taking approval from NSRC. Our null hypothesis was there will be no change in body composition and aerobic fitness as we initiate the basic police training, and the alternative was of being there is a change. Here the exposure was the basic police training, and the outcome was body composition, which is fat percentage, and the aerobic fitness, which is measured by VO2 max. And this article was presented as per the STROBE guideline. All the 22 set of points were addressed. And the sample size was calculated as per the hypothesis testing. First, the null hypothesis was created, followed by the alternative hypothesis. Alpha and beta error was defined, which was 95% and 80% respectively, and which came out to be 543. With the 5% of non-respondent rate, it came out to be 570. So regarding the tools in the VO2 max, in calculation of VO2 max, we asked the trainees during their performance analysis to run for 12 whole minutes, and the distance cover was recorded. This distance cover was then put in the formula given below, and then the VO2 max was calculated. These are the two tables giving the reference range of VO2 max segregated as per male and female and the age. We measure the body composition with the help of the a measuring tool called skin fold caliper in 7 different anatomical sites. Our dependent variable here was gender, age, the fixed scale diet, and the physical exercise, whereas the independent variable was VO2 max, fat percentage, and total body weight. We did a systematic random sampling. By calculating the sampling range, which came out to be 15, the candidate which lie in the 15th interval were taken. So after we plotted that in Microsoft Excel of 2013, we found out that the histogram shows the normal distribution. That's why we use the parametric test like peer t-test, and we use our program for the analysis of the data. As this was the cross-section analytic study, we addressed the confounders with the help of matching, restriction, and randomization. Matching was done as per age and gender, and the restriction was done as per the exclusion criteria, like the anatomical variation, like knock-knee, flat foot, scoliosis, and other different comorbidities. So our result after analysis was the participant characteristics were 72% were male, and 21 was the mean age, average age, and the most of them were in the normal BMI status. So in the main finding, we found out that the BMI and fat percentage decreases in both in male and female, as well as the VO2 max increases, which is the cardiopulmonary fitness parameter, which increases with the basic police training. So with this in mind, our conclusion was, if we could generalize this kind of regimen of exercise and diet in a general population, then we could increase the occupational performance, decrease the non-communicable disease, NCD, which is the future pandemic, and also increase the health of the general population where we apply it. These are the reference of mine. Thank you.
Thank you. Now I request Tarak Thapa for his presentation on multi-morbidity, stress, anxiety, depression, and quality of life of older Nepali adult.
Thank you, sir. Distinguished dignitaries, cheers, my dear friends. Today, I'm on the behalf of my research team. I would like to present about the research, which is basically about the quality of life of older population of Eastern Nepal, and there are some underlying factors we found out that they are affecting the quality of life of older population in Eastern Nepal. So I would like to present the research on. So the topic is multimorbidity, stress, anxiety, and depression, and quality of life of older Nepali adults. The study was conducted in eastern Nepal. We selected 2 districts of eastern Tarai region, Sunsari and Morang. Our study team, what happened? Sorry. Okay, left, right. Yeah, thank you. So this is our research team. We comprise of 9 members. So as we know that as the population grows older, that comes with lots of responsibility for the country to fulfill the social and health needs of the older population. So in our country, especially in the Eastern Tarai region, that we have in the different the previous research that we had found out that the multimorbidity and physical and mental condition that is really prevalent in the older population, and that is also affecting their functional capacity and the other the health related consequences of the older population. So this is some of the research that I would like to highlight here, which found out that there are some problem in the older population and their quality of life, as well as their functional capacity, which are connected to their physical and mental conditions. So this is the rationale of our research. As you know that there are many government policies that have been provided, some subsidies, social securities that have been provided by the government, especially to address the needs of social needs of the older population. But still many older people are not aware about that. And as well as there are some previous researches which have found out that quality of life, especially in the nursing homes, semi-urban areas, hospital-based researches that have found out that there are some quality of life issues among the older population. But these researches were not conducted in the the rural settings. But we found out that is one of the the good rationale for our study. And as well as another rationale is that there are some evidences that has to be the investigate the quality of life and the associated factor with the those quality of life like physical and mental related factors which can impact the quality of life of the older population. So these are the 2 major objectives of our study. First one is to assess the health related quality of life, which is HRQOL of older Nepali adults, and another is to investigate the association of multimorbidity and depression on quality of life. So this is the study design. This is the cross-sectional studies, which was conducted in Sunsari and Moran district. Sample size is 847, 60 and 60 plus older population. This is the multi-stage cluster sampling. And we generally come up with the theory that the depression, anxiety, stress and morbidity that are most related with the health-related quality of life of older population. And another one is, this is the tool we have used to assess the health-related quality of life of older population. This is the 13 indices. This tool consists of 13 indices related to older people quality of life, and the items were summed up. Then positive items were reverse coded so that the higher scores represent the higher quality of life. So another tool that we have used is DASS tool, which is Depression Anxiety Stress Scale, which has 21 indices to assess the depression, anxiety, and stress among the older population. And the scores of depression, anxiety, stress were summed up separately, and each was categorized as normal, moderate, and severe. So the indicator that we have taken is, it's not an indicator, so multimorbidity, which is we have categorized in 3 major categories: no morbidity, single morbidity, and multiple morbidity. This is the small tool that we use to assess the morbidity status among the older population. So basically, when coming up to while discussing about the results, that we found out that older people quality of life score was, the mean score was 42.8. Where is the standard deviation plus minus 7.1. And I cannot see the file, excuse me. Sorry. So we found out the depression, talking about the depression, we found out that the 30% of the older population had moderate to severe depression, 34% had moderate to severe anxiety, 21% had moderate to severe stress, and 48% of the older population had at least one morbidity. So this is the ANOVA analysis of variance to assess the health-related quality of life and its relation with the depression, anxiety, stress, and morbidity. So summarizing it, mean health-related quality of life is lower among those with the moderate to severe depression, anxiety, stress, and morbidities than their respective counterparts. So we can say that the health-related quality of life is low among the older population which has the moderate to severe level of depression, anxiety, and morbidity, at least one kind of morbidity. So this is the multiple linear regression, which is I want to just summarize it. In adjusted regression analysis, quality of life was found to be low among those with the moderate to severe depression and anxiety. Similarly, compared to the participant without any chronic conditions, those with the single morbidity and the multiple morbidities were found to be experiencing lower quality of life score. And the findings were not significant for this stage, so the stage was not selected for the model. So concluding the study, that I would like to say that our findings suggest that the poor physical and mental status can have impact with the quality of life of the older population. So another conclusion we did that there is a need to design and test people-centered comprehensive preventive measures and management program focusing multiple levels of health facility to improve the quality of life of older adults living with the physical and mental condition. And further research investigating the potential moderating factors are also need to be found out. Thank you. And at the last, I would like to thank the NHRC for the grant support for this study. This was, conducted with the grant support from the NHRC. And I would like to thank Dr. Uday from the University of North South Wales and Miami University and the Center for Research Policy and Implementation. Thank you.
Thank you. Thank you, Mr. Thapa. I now move on to 8th presentation on varicella zoster outbreak in a military training center in Nepal, a clinico-epidemiological study presented by Dr. Lee Bulathuki. Dr. Bulathuki, floor is yours.
Slides, please. So, the topic of our study is varicella zoster outbreak in a military training center in Nepal. It's a clinico-epidemiological study. So, as we all know that chickenpox or varicella is a highly infectious disease, and the primary infection is caused by varicella zoster virus with an incubation period lasting up to 21 days, and it's characterized by fever, rash, and then you've got malaise. And then these cases are more common in winter and spring, and especially in countries like Nepal and India, where we do not have vaccination in our immunization schedule. These type of cases occur quite frequently in young school-going children. And it's also common in adults in institutional settings like ours, in the military and in hostels. So in our context in the military barracks, this is an important health issue because we all know that chickenpox in adults takes a more severe course of disease, and complications like pneumonia, encephalitis, cerebral ataxia, bacterial superinfections can occur. So so our study was aimed to study these features of varicella zoster when one outbreak occurred in a training camp of Bhaktapur. And then we also aimed to see what our secondary attack rate would be, what clinical features does chickenpox present in our setting, because we've just read that in books. So we thought we'd check all these things by doing this outbreak investigation. So this outbreak actually occurred in a Ranger Regiment training center, which is in Nagarkot, 30 kilometers from Kathmandu. And then who were infected were admitted in SVH. And I'd like to draw attention that the Ranger Regiment performs a very strict training. Like there's a complete 6-month training where they can't even go home and outings and all. So this was in a closed institutional sort of setting. So this looked like a good opportunity to study this disease. So we, like when the first case was reported in February 5th, 2020, we formed the outbreak investigation team. And when we looked into the data, we compared data of last 3 years, we saw that there was an outbreak. So we prepared case definitions, which was aligning with CDC's definition. And then we went on to investigate the cases, definitions for clinical case, probable case, and confirmed case, close contacts, and susceptibles were prepared beforehand, before we moved on to investigate the outbreak. And then this center was visited the very next day when the case was reported, and then we interviewed all the people that they were in that closed institutional setting. And we also observed the dining area, the living accommodation, the classrooms, and data was taken in a pre-designed pro forma. And then cases were observed till 42 days, that is the 2 incubation period time. And forward contact tracing was done for further new cases. We also aim to see the backward tracing to find out where these cases came, where the first or the primary case came from. Case management was done in Sri Birendra Hospital by standard protocol, and data management was done by keeping the data in SPSS and analyzing in Excel and analyzing in Excel itself. And ethics approval was additionally taken from the ethics board of the institution. So we found that the cases had occurred in winter season, which is quite similar to what other research and what other literature was reporting. There were 167 all male personnel in that center, and out of them 125 were in the training itself, where the first case occurred, and 42 personnel were others. That meaning they were like the trainers, cooks, the security personnel, and cleaning staff. So we made a list of all these people, and we took the history. We found that 67 of them already had chickenpox by this age. So the average age was 22 years. So this was very interesting finding for us, that by the age of 22 years, 42% of usually young Nepalese would have suffered from chickenpox. So this we found quite interesting. We also found that no one was vaccinated by chickenpox. And so by deducting these numbers, we found that 90 people were susceptible to getting chickenpox in this training center. We found, when we saw the training the center, we found that there was overcrowding. There was classes being taken in one room, and they were trained together. And this is a very harsh training where body contact, harsh training where even the trainees and the trainers come in very close contact. So most of them were actually in the in contact with these cases. So as soon as we found these cases, preventive strategies were applied, which was standard for chickenpox. And additionally, what we did was, since there were so many people already infected, we formed a barrier sort of thing. Even in the living accommodation, we separated people like vaccinated, the infected, and non-infected people were separated by the infected people. So, and twice a day, the trainees were checked for chickenpox. So this is the epidemiological curve. What we can see is that the case that was reported to us, the index case, was not the primary case. When we further went back, we found that the primary case had actually already occurred in 7 December 2019. And since this is a very important career course, the management was not as done as we expected. And then this primary case, like I said, this training was occurring since 6 months. So this case has actually been in contact with a herpes zoster case. And when we looked into research, we found that these cases has been reported that the primary case would be a zoster case, that is, हामीले जनै खटेरा भन्छ नि, त्यसबाट चाहिँ यसरी outbreak report भएको छ. So we found this was a very interesting finding. The other results, what we found was that out of 22 other personnel, 16 were only close contact, and altogether 18 cases was reported during this outbreak. And we found that the secondary attack rate for this outbreak was 21.43%, which is low as compared to other studies by Sinalcor or even WHO. And we also found out the mean admission days was also less, which could be due to the importance of this training, because if they would be admitted for long, the training would automatically it would be cancelled. And the other important things was the first clinical case usually reported in our case was headache. The common clinical symptoms was rash seen in 100% of cases and followed by fever, body ache, and malaise. And this is also in par with other studies reported in other military settings, like by Indian settings. And we also found that since rash was the most common feature, we studied rash a little bit, and then we found that the rash started in head and neck in 44% of cases in our setting. But the distribution was centripetal in 66% of the cases, and no complications were seen in our cases. What we feel is the strength of this study is that it studied an ongoing epidemic, you know. So that's why, and in a restricted institutional setting where there was no contamination from outside. So this, we feel, was the strength of the study. The weakness which we felt was there was no lab confirmation of this, you know, the virus. And but we used dermatology department's expert to identify the cases and then confirm the diagnosis. Also, we did not do a seroprevalence, serosurveillance among the trainees. We relied exclusively on history, whether they had chickenpox in the previous history of chickenpox or not. So this is also a weakness. And obviously, since it's in a military setting, the generalizability is only to military settings. So to conclude, this study has helped us to study a natural history of varicella zoster in an institutional setting. And we studied epidemiological as well as clinical characteristics in our research. And we found that secondary attack rate was less as compared to other reported literature. And it could be because of the strict preventive measures that we could apply, primarily because it was a military training center. In training, whatever we say is being, is done by the trainees. Secondly, also what helped was this outbreak occurred immediately, at par with COVID, the first COVID cases. So,
1 minute.
So the first COVID cases. So that's why even all outings and the strict, whatever we said, even respiratory measures were quite strictly observed. So that's why I think the secondary attack rate came out less. And lastly, adding up to the theme of this conference, we think that a resilient system should be made in context of these, that all diseases of outbreak potential, especially in the military, because infectious disease spreads like a wildfire, we would like to suggest that there should be a policy to investigate all these types of outbreaks. And I would like to acknowledge the training school and the camp commander. And even though the researchers involved in this research are affiliated to the army, there was no support or sponsorship granted to this study. These are my references. And I would like to thank everyone for listening.
Thank you. And now I request Sheila Thapa for his good presentation on occupational health and safety among airlines crew members.
Respected chairs, dignitaries, fellow presenters, and dear audience, Namaskar. I am Sheila Thapa, Assistant Professor at Karnali Academy of Health Sciences and Principal Investigator of this study named Occupational Health and Safety Among Airlines Crew Members in Nepal. Moving on the background, okay, I would also like to acknowledge my co-authors, co-investigators of this study. Moving on the backgrounds, I would like to first, we have seen occupational health and safety is the science concerned with the protecting the safety and health, health and welfare of the people engaged in work. And then the unique nature of the occupation, like aviation sector. At some point of our life, we may have envied them, or we might have admired. Though we have admired and we also wanted to get into that occupation, we may not know that and there have many hazards. So, and many studies had proved that the flight attendants and crew members may face many acute and chronic health status. And it may be fascinating to observe the world from the altitude of thousands of meters above. It also poses the same characteristic lead to the sum of the risk factors like exposure to electromagnetic field, radiation, low humidity, and so on. So there is high likelihood of the development of the various symptoms, acute and chronic symptoms in the airline pilots and cabin crew. So, and there are, though the Nepali aviation industries has the glorified 71 years of the history, there lacks these kinds of study. So we intended to do this study, conduct this study. So then the objective of this study was, general objective of this study was to assess the status of the occupational health and occupational safety and health vulnerability among airline cabin crew, our airline crew members in Nepal, and assess their reported health problems. And the specific objectives were to assess the reported health problems of the pilots and cabin crew, to identify the level of the knowledge on occupational health and safety among them, and to measure the occupational safety and health vulnerability among them. It was a quantitative cross-sectional descriptive study, and the samples were selected from the census method, and we mailed them a self-administered questionnaire. It had it was self-developed by the researcher, and it also included occupational vulnerability hazard and vulnerability measure tool that was developed in Canada in 2016 by the Institute of Work. So as we could not contact all the participant in direct approach, so we adopted online platform for the data collection, and data was collected for the period of 4 months, and the data was analyzed in descriptive statistics. And the main features of the data, socio-demographic characteristic of the crew members were like the mean age of the 34.18 plus, with a standard deviation of 9.85 years, and most of the respondents were male, and their educational status, 44.7% had completed their bachelor's level. Okay. So, coming on the occupational characteristics, most of the respondents were from the private sector, and they were involved in international flight routes, and most of the respondents, almost half and more of the respondents were pilots. And then, although they reported, almost all, that is 97.2% of the respondents reported that they had no history of the comorbidities, and their perceived health status were good, and they are under regular medical checkup. This report on the reported health problems shows that 9 out of 10 crew members reported some kind of health problems in past 6 months, and headache topped the chart. One-third of the crew members, only one-third of the crew members had adequate knowledge on occupational health and safety. And overall prevalence of the occupational hazard, occupational safety and health vulnerability was 100% among crew members. As I had already said that they had to work in the thousands of above the thousand of altitudes. So although 90% of the crew members had adequate awareness of their occupational health and safety rights and responsibility, only 39% had still 39% had inadequate access to workplace policies and procedure, and a total of 36% of the crew members had inadequate engagement in participation in prevention of the injury and illness. So we can conclude that most of the pilots and cabin crew, that is 9 out of 10, had reported health problems in past 6 months, although we have already known that they go under the regular medical checkup, and only 1/3 of them had adequate knowledge on the occupational health and safety. All participants were exposed to the hazards, so they were vulnerable to the hazards, occupational hazards, and we would like to, and this study also concludes that the concerned authority of the aviation sectors need to put forward on the policies and some procedures through which they can orient their crew members about the risk, occupational and non-occupational risk to their health, and then empower them with awareness. Although this study has the glory of being first of its kind in aviation history that measures the occupational vulnerability and assess the knowledge of the crew member, it had some limitations also. Due to the high non-response rate, the study sample size was limited to 141, so the sample size was reduced, so the generalizability of this study can be arguable due to the small sample size. And I would like to take this opportunity to acknowledge Nepal Health Research Council for providing us with the provincial grant, and Civil Aviation Authority of Nepal for all the administrative support, and of course the crew members who, despite of their busy schedule, involved in this study, and to all my dear audience for having this much patience to listen my presentation. Thank you.
Thank you, Shilaji, for your timely completion of the presentation. The floor is now open for any questions for the last 4 presenters, 6, 7, 8, and 9. Please, mic dinusta.
First of all, thank you for such an information from all the presenters. My question is for Dr. Vivek Raj Bhandari. As you have mentioned, study site as Nepal Police Training Center, how many centers were there during data collection process?
Hello. हाम्रो डाटा कलेक्सन सेन्टर चाहिँ टोटलमा चाहिँ 23 वटा थियो, होल नेपालभरि ट्रेनिङ सेन्टरहरू। त्यो मध्येमा चाहिँ हाम्रो 3टा सेन्टरमा चाहिँ 2019 को रिक्रुट्सहरू जाँदै गएन। भनेपछि हाम्रो 20 वटालाई चाहिँ हामीले लिएर त्यो अनुसार सिस्टमेटिक र्यान्डम स्याम्पलिङ गर्दाखेरि जुन चाहिँ 15 को इन्टरभल आएको थियो, हामीले त्यसरी चाहिँ अगाडि लिँदै गयौँ। 20 वटा भयो टोटल स्याम्पलिङ त्यो ट्रेनिङ सेन्टर्सहरू चाहिँ।
Or a question?
Okay. Physical fitness is a matter of interest for all of us. So I think that's why many people are very inquisitive regarding physical fitness. So my question is again directed to Dr. Raj Bhandari. So you said that at the end of your slide, you said that if we could generalize exercise, just like we did in the police regimen, in terms of doing physical fitness and in terms of calorie intake to the general population, then we would have a healthier population. Yes, but I think in police, when they recruit the police people, I think they recruit the cream of the society in terms of physical fitness. They only recruit people who are really physically fit and also who are young. But general population comprises of a variety of people. It's a heterogeneous mass. So it comprises of young as well as old people and as well as people who have comorbidities. So how can we generalize that physical fitness in general population or like in people like me who are a mother? So how can we find an exercise that is tailored to our needs? Thank you.
Thank you हजुर। क्वेसनको लागि एकदम थ्याङ्क यू हजुर। खासमा चाहिँ यो जेनरलाइज गर्न चाहिँ नमिल्ने हो नम्बर 1 किन भन्दाखेरि यसमा चाहिँ एकदम फिट र एकदम हामीले चुज गरेर लिएर आएको मान्छेहरू हुन्छ तर यसलाई जेनरलाइज हामीले जस्तै अब यो गर्ने बेलामा चाहिँ यो स्टडी गर्ने बेलामा हामीले कम्युनिटीमा गर्दाखेरि अलिकति अनइथिकल देखिन्थ्यो जुन चाहिँ 3 महिनासम्म कन्फाइनमेन्टमा राखेर हेर्दाखेरि अरू कन्फाउन्डर्सहरूलाई हामीले निकाल्न खोज्दाखेरि चाहिँ त्यति राम्रो देखिन्न थियो गरिन पनि सकिँदैन थियो होइन त्यही कारणले गर्दाखेरि भित्र कन्फाइन भएको मान्छेहरूलाई मात्र गऱ्यौँ त्यो चाहिँ हेल्दी पपुलेसनमै भयो इभन यो चाहिँ हामी जेनरलाइज गर्न सक्यौँ भने पनि थोरै केही चेन्ज आउँछ कि भन्यो जेनरलाइज गर्नको लागि चाहिँ मेरो स्टडी हामीले जुन स्टडी यो गऱ्यौँ त्यो एनालाइटिक क्रस सेक्सनल थियो अब हामीले यसलाई जेनरलाइज गर्नको लागि चाहिँ एउटा कम्युनिटीमा गर्नु पऱ्यो ओभरअल सबै जेनरलाइज पपुलेसन भएको ठाउँमा र 2 नम्बर कुरा चाहिँ एकदम त्यसमा चाहिँ इन्टरभेन्सन स्टडी चाहियो त्यसको लागि चाहिँ अब हामी अलिकति त्यसमा चाहिँ बजेटदेखि लिएर अरू सबै कुराले चाहिँ कमी थियो त्यो कारणले गर्न सकिएन तर हजुरको जुन चाहिँ क्वेसन थियो अब कसरी गर्ने त भन्दाखेरि चाहिँ त्यो चाहिँ अब यो स्टडीको बाहेकको कुरामा चाहिँ यसमा चाहिँ प्र्याक्टिकल कुरा एस्पेक्टमा जानुपर्छ रिसर्च र अरू पाटोहरू त धेरै छ तर प्र्याक्टिकल वेमा चाहिँ अब हामीलाई थाहा भएकै अनुसार चाहिँ त्यो डायट र एक्सर्साइजको प्याटर्नले गर्ने हो तर एक्सर्साइजको प्याटर्नले भन्नुपर्दा पनि जुन चाहिँ लिटरेचर रिभ्यू गर्दाखेरि मैले भेटेकोहरूमा एक्सर्साइज भन्दा पनि डाइटले चाहिँ बेसी कन्ट्रोलतिर जाँदो रहेछ अब त्यो पाटो चाहिँ म हजुरलाई पछि कुनै बेलामा पनि त्यो भन्न सक्छु हजुर सेयर गर्न सक्छु हजुर
Thank you, Dr. Bivek, for a nice presentation. My question to Dr. Bivek Raj Bhandari is that does the ethnicity matters on the body composition in aerobic performance? Like there are different ethnicity in the background, like the Rai, Mughal, Sherpa. So does the ethnicity matters on the body composition in aerobic performance in the police training?
Again, thank you for the question, हजुर. तर यो एथनिसिटीले त गर्थ्यो नै होला हजुर. तर यसमा चाहिँ मैले एथनिसिटीलाई इन्क्लुड नगरेको थोरै कारणहरू चाहिँ छ जुन चाहिँ हामीले कन्फिडेन्सियालिटी मेन्टेन गर्नको लागि पनि हो. नेपाल प्रहरीभित्रको कुराहरू हामी सबै फेरि त्यसरी ओपन अप जाँदाखेरि अलि अप्ठ्यारो पनि होला जस्तो लागेर पनि मैले एथनिसिटीलाई चाहिँ हेरिनँ. तर एथनिसिटीले अफकोर्स म्याटर चाहिँ गरिराखेको थियो जुन चाहिँ हामीले बियोन्ड त्यो कन्फिडेन्सियालिटी पछाडि बसेर हामीसँग र डाटा एनालाइसिस गर्दा चाहिँ अफकोर्स थियो. त्यसमा चाहिँ आएको मध्येमा चाहिँ एउटै पपुलेसनमा चाहिँ अलिक जुन पपुलेसनमा बेसी छ त्यो पपुलेसनमा चाहिँ राम्रो इम्प्याक्ट अझै बेसी देखिएको देखेछ हजुर. थ्याङ्क यू.
Thank you. Any other questions from the participants? Floor bata. Before closing the session, let me ask questions to both the presenters from different forces. A single question to both. How did you assure ethical conduct of a research in a closed hierarchical settings? And how did you assure that their autonomy is not compromised?
यो त अब हामीलाई थाहा भएकै कुरा हो चेन अफ कमान्डमा हामीले भने पछाडि सिनियरले जुनियरको काम गर्नै पर्छ त्यो जुनियरले अब गर्नै पर्छ त्यही भन्न खोज्नु भयो होला सरले हैन सर. र त्यसमा चाहिँ हामीले एउटा के गरेको थियौँ भन्दा एउटा ओरिएन्टेसन क्लास राखेको छौँ. त्यहाँ मैले मेन्सन गरेको थिएँ हजुर. ओरिएन्टेसन क्लासमा चाहिँ कम्प्लिटली त्यो इभन मेजरमेन्टको लागि चाहिँ मोटिभेसन अब्लिगेसन हैन मोटिभेसन प्लस हामीले चाहिँ त्यहाँ के भनेको थियौँ भन्दाखेरि यो हामी आफूले अरूसँग कम्पिट गर्ने होइन आफूले आफैसँग विथ टाइम कम्पिट गर्ने हो. प्लस हजुरहरूले चाहिँ यो हामीले जुन चाहिँ ओरिएन्टेसन क्लासमा एकदम कम्फर्ट वेमा लगेर इभन नन ड्रेस नभएको सिचुएसनमा बसेर त्यसरी चाहिँ मैले गर्न खोजेको थिएँ. तर स्टिल त्यहाँ पनि त्यो हेर्दाखेरि कतिपय कुराहरूले अब त्यो दर्जाको हिसाबले पनि थोरै अब सान दर्जाको लागि चाहिँ गर्नै पर्ने जस्तो लाग्न सक्छ. त्यो एथिकल इस्युज त आर्मी पुलिसमा हुने नै कुरा भयो हजुर.
Thank you, sir. Actually, मेरो स्टडी चाहिँ आउटब्रेक इन्भेस्टिगेसन हो अनि त्यो चाहिँ हामीले भन्यौँ नि अगाडि नै पनि अलिकति केसेस भइरहेको हुनाले चाहिँ त्यो ट्रेनिङै रद्द हुने अवस्थामा गइसकेको थियो. उनीहरूको 7 days भन्दा बढी लिभ भयो भने चाहिँ रेन्जर्सको त्यो ट्रेनिङ चाहिँ उनीहरूको अफै हुन्छ. त्यो कारणले गर्दा चाहिँ मोटिभेसन चाहिँ सबैमा हाई नै थियो कि यो आउटब्रेक स्टप गर्नुपर्छ. अनि आउटब्रेक्सलाई चाहिँ अब हामीले एक्चुली एथिकल कन्सेन्ट लिएर आउटब्रेक रोक्न जान्छु भनेर चाहिँ हुँदैन. भएपछि हामी नेक्स्ट मर्निङै गएको हामीले थाहा पाएपछि. सो इभन दो त्यही रात नै हाम्रो चाहिँ अनि एउटा चाहिँ स्ट्रेन्थ चाहिँ अहिले जुन एनएचआरसीले गरिदियो आइआरसी चाहिँ हाम्रै डिपार्टमेन्टको जस्तो कम्युनिटी मेथ सेन्टरमै भएको भएर त्यही रातै हामीले गरेर नेक्स्ट डेसम्म चाहिँ एकदम फास्ट रिभ्यूमा पठाएर र यसमा चाहिँ अब त्यही अहिले हामीले भनेको जस्तो सबै खुलाएर लेख्दाखेरि चाहिँ हामीले चाहिँ 1 डेमा चाहिँ एक्सपिडेड प्रोसेसबाट चाहिँ हामीले आइआरसी पायो त्यो एउटा भयो. तर एक्चुली चाहिँ मेरो विचारमा चाहिँ आउटब्रेक्सहरू चाहिँ बाहिर वर्ल्ड वाइड पनि एथिकल कन्सेन्ट लिइँदैन किनभने यो चाहिँ ट्रुप्सको हेल्थसँग रिलेटेड हुन्छ. अर्को चाहिँ हजुरले भनेको जस्तो गरेर चाहिँ अर्को मैले अघि पनि हाइलाइट गरेँ ठ्याक्क यो चाहिँ फेब्रुअरीमा भयो कि 2020मा ठ्याक्क त्यो बेलामा चाहिँ कोभिडको यस्तो स्केयर थियो कि अब यो पनि रेस्पिरेटरी र कन्ट्याक्ट र कोभिड पनि एकदम म्याच क्याच भएको हुनाले चाहिँ हामीले चाहिँ त्यसलाई चाहिँ क्यास इन पर्सनली मैले चाहिँ एकदम क्यास इन गरेँ कि जे कुरा चाहिँ आउटब्रेकमा यो आउटब्रेकमा गऱ्यो भने चाहिँ त्यसले कोभिडलाई पनि हेल्प गर्छ भनेपछि उहाँहरू त्यो ट्रेनिङको जो हाम्रो कमान्डर हुनुहुन्थ्यो उहाँ पनि एकदमै नै एन्थुजियास्टिकली गर्नुभयो र त्यो हामीले इन्टरभेन गरिसकेपछि चाहिँ एक्चुली त्यही एउटा इन्क्युबेसन पिरियडभित्र जति केस भयो नि त्यसपछि चाहिँ हाम्रो त्यो पछिको चाहिँ आउँदै आएन क्या सर सो त्यसलाई चाहिँ हामीले एकदमै हाम्रो चाहिँ एउटा एकदम ह्युज अचिभमेन्ट सोचेको छौँ सर सो त्यो चाहिँ हामीले त्यही भएर यसमा चाहिँ एथिकल कन्सर्न चाहिँ यसरी अलिकति ट्याक्टिकली चाहिँ सल्भ गऱ्यौँ सर हस् थ्याङ्क यू
Now, before concluding, I like to ask Tarak Thapa how stress, anxiety, and depression will change the quality of life.
Thank you for the question, sir. Actually, stress, anxiety, and depression, those factors doesn't change the quality of life. Those impact the quality of life, and if we work to decrease the stress, anxiety, and depression among the older population, that will surely, enhance the quality of life. That will surely ensure the better quality of life for the older population.
What is the change in the brain?
Sorry, sir.
It is related to the change in the brain. I have worked 1 year in psychiatry, so I was asked these questions. There is a release of serotonin, you see. The brain will shrink and then the patient mood will change, you see. So, unless and until you know the physiology a little bit.
I understand your concern, sir. Actually, there is exclusion criteria that we have clearly mentioned in our study. So we exclude those patients which are mentally unstable, which are in those conditions that we exclude those participants from the study, sir.
Thank you. And I'd like to ask Dr. Buddha Thoki, what I have read in paper yesterday, very solar adjuster what work in the military in Norway or something like that. There was people who are in the dormant, they are infected. But those people who are dying just by the side of in the room, they are not infected by the varicella adjuster. What is your idea about that? Inside the room all are affected, but just by the side of the room there is another person or top leader of a military, they are not affected.
Sir, in our, I cannot speak for the whole of the world, but in our setting, they were residing in 4 rooms and all 4 rooms had those 18 cases maybe because the classroom was common and the eating, dining and the training was common, so that's why it could be, sir. But teachers were not involved, sir. So,
Why it is not involved? These are questions.
That we could not solve, sir.
Okay.
Thank you, thank you. Thanks a lot for all the presenters. Now I'll hand over to our organizer to proceed further.
Thank you, sir. With the permission of our chairs, we have come to the end of the session. I would like to thank our chairs, our presenters, and all our audiences for making the session productive and informative. Further, I would like to request our chair to provide the token of love to our presenters. I request our presenters to move forward to receive the token of love. Ms. Uma Kafle. Mr. Rajendra Gautam. Ms. Mandira Adhikari. Mr. Pramod Kumar Mehta. Dr. Bivechan Thapa. Dr. Vivek Raj Bhandari, Mr. Tarka Thapa, Dr. Lee Budathoki, and Ms. Sila Thapa. Moving forward, I request the chairperson of Nepal Health Research Council to honor our respected chairs with token of love. Thank you, sir. I thank the chairs, presenters, and audiences for making the session really productive. Thank you, everyone. Stay connected for tomorrow's Day 3 program. And please join here for a photo shoot. Also, do enjoy the dinner and cultural program. Thank you very much.